Welcome to the LifeBeat podcast, a One Joshua Group production, providing access to information and experts to improve quality of life and health outcomes.
Hello, I'm Kermit Payne, and welcome to LifeBeat, the podcast. Today, we're diving into the critical intersection of healthcare, data, and global equity. And we often hear disparities and a lot about what disparities are and should be, but our guest today is going to push the conversation forward by tackling the foundational issues of data scarcity and the need for culturally relevant solutions. Joining us today is Dr. Yvonne Commodore-Mensah, a dynamic leader who uniquely blends nursing, teaching, and research to tackle global health challenges. Dr. Commodore-Mensah is Professor and Associate Dean for Research and Director for the Local-Global Reciprocal Innovation at Johns Hopkins Center for Health Equity. She's a prominent voice in addressing heart health disparities, and particularly in regions like West Africa. Her work moves beyond simple access to care and focuses on closing a critical data gap and championing culturally informed innovation. She advocates for reciprocal innovation, and we are excitedly and pleased to have Dr. Yvonne Commodore-Mensah to talk to us about the next generation of nurses and how we can be better literate innovators on the healthcare frontier. Dr. Commodore-Mensah, thank you for joining us.
Thank you so much, Mr. Payne, for having me.
Good. It is always our pleasure to talk to you and to see you again. So we want to start with the heart of your work, and that is the blending of nursing, teaching, and research. Now, how does this multi and interdisciplinary approach fundamentally change the way that we, A, understand, and secondly, tackle the complex issues like heart health disparities?
That's a great question. And getting to the heart of the answer to that question is the fact that I stumbled into my nursing career. Most people I know who are nurses, I've always knew they wanted to be nurses. And at some point, I wanted to be a pilot, then an engineer. And then I saw a Johnson & Johnson poster that said, "Dare to join the ones who care." And so this was in college. And during my first week of college, I happened to be in the School of Nursing building to drop a form to register for another class and saw this poster. And I made that instant decision to change my major to nursing. And this was much to the chagrin of my father, who preferred that if I were to choose a career in healthcare, it might be to become a physician. But I instantly decided I wanted to become a nurse. And so after working for several years, taking care of patients and people with heart disease, and also being exposed to disparities in care. What do I mean by that? So I took care of patients diagnosed with heart failure, hypertension, people who were recovering from different cardiovascular conditions. And I saw a consistent theme of readmissions in certain populations and worse outcomes in certain populations. So, as a curious person, I dove into the literature to understand sort of why health outcomes, and especially cardiovascular health outcomes, were worse for some populations versus the other. And then I saw that the literature focused mainly on sort of Black versus white disparities. And you would often see statements like, Black people are more likely to have hypertension, diabetes, kidney disease. And that's where it ended, right? Without talking about what are the reasons why these disparities exist. And most importantly, what are we going to do about them, right? So moving beyond just describing disparities to using the evidence that's available to implement interventions in communities locally and globally. So that's where my heart is, taking everything that we know about ways to prevent and manage cardiovascular disease and taking that to the people and designing community based interventions in faith based settings, in other community based settings to increase awareness of
Mm-hmm.
heart disease, to increase awareness of the risk factors so that
Mm-hmm.
people understand that 80% of heart disease is preventable, right? So,
Mm-hmm.
how do we get the message out, not just locally in the US, but also across the ocean to sub Saharan Africa, where we're seeing a higher burden of heart disease?
Mm-hmm. So you bring a multidisciplinary perspective as I'll say, an educator first, and a researcher, and then a nurse. And going back to what your dad said, so what does that perspective as a nurse and a public health expert, how does
Mhm.
that perspective differ from that of a physician? And then in the same direction, this holistic to being in this place, seeing something that triggered your heart about caring. What about the holistic place in your heart, and that how it is the same or different from that of a physician?
First, I'll say that healthcare is a team sport. And my favorite sport
Mm,
is soccer. People call it football. So when we think about healthcare as a team sport, everyone has a role and everyone's important. Physicians are important, nurses are important, pharmacists, social workers, everyone has a role to play. But I think the magic in nursing is that from our training, we're taught to look at health not just as the absence of disease, but think about health more broadly in terms of a person's well being. So, when you're trained as a nurse, you are taught very early on from your first semester to think about health not more broadly, not just in terms of clinical factors, but what we call social determinants of health. What are some of
mm-hmm,
the reasons why, for instance, a person may not take their blood pressure medications as prescribed if they have issues with transportation, if they are stressed out, like their psychological and mental health. So we are trained from a very early on to think about health more broadly. And I also have the unique opportunity to blend principles of public health. So I also fell in love with public health and epidemiology as a doctoral student. And I fell in love with public health because although as a cardiac nurse, I had the opportunity to care for patients one on one and educate
mm-hmm,
them, like you said, I'm an educator at heart. I've always loved to teach in different settings. In fact, that's one of the things my mom said growing up, that instead of doing my homework, I'll gather children in the neighborhood and teach them
mm-hmm,
and about different things. So I've always loved to teach. And being a cardiac nurse and teaching patients at the bedside about, how to manage their condition was helpful, empowering, and I enjoyed it. But public health allows you to have an impact millions at a time. In
mm-hmm,
fact, that's one of the mantras of the School of Public Health that I was able to get additional training in epidemiology, which is that how do we take the knowledge that exists and the evidence and think about developing programs that would touch thousands and millions of lives. So having the opportunity to have a greater impact on that scale is something that excites me, but also thinking about team science, right? And that's also the beauty of blending my nursing training with my public health training, but also partnering with physicians in different disciplines to see how we can put our heads together to tackle this global health problem of heart disease. Because I would say no one profession or discipline has all the answers. And so I get to design programs and collaborate with others to really see how we can innovatively tackle the burden of heart disease locally and globally.
So we talked about how often diseases occur in some populations versus other populations. It's referred to as the disparity of health. We know something about that. And you talked about the issue of access to care. So there's another element in making people's lives better, and that's knowing more about their lives. Evidence. You mentioned the need for evidence. Your work looks at a critical issue with the lack of data, the evidence of what happens, in ways that we can close some of these gaps, particularly in regions like West Africa. Why is it so urgent that we look at closing these gaps? And what do you think we're missing when the data is not present?
As you pointed out, whenever there is a gap in data or knowledge, we don't have enough information to plan, to strategize. And I became aware of this data gap first as a doctoral student in the US when I wanted to understand what the burden of heart disease and risk factors are in African immigrants in the United States. So I conducted a search of the literature to see who's done work in this space. And I didn't find a single study looking at the heart health of African immigrants in the US. And so I started to ask questions, which I often do. Why does this gap exist? And one of the reasons is that when we think about health equity and health disparities as well, um, we often tend to lump groups together based on the color of your skin, right? So in the US context, we know that we have African Americans who are descendants from the transatlantic slave trade, but we also have Black people in the US who voluntarily migrated to the US from the Caribbeans, from Africa. And so, in terms of our traditional approach to research, if those groups are represented, the foreign born groups, we just lump them all together and compare them to white people. So, one of the cases I made early on is that when we do that, we lose a lot of information, right? Because there may be some differences in, as you alluded to, healthcare access. We know that the healthcare system may be difficult to navigate for the average American, but also for foreign born Black adults. And there are also differences in perceptions about heart disease, the causes of heart disease. There are differences in diet, right? And the culture, and all of those factors matter. So I've always advocated for disaggregating data, but closing gaps in knowledge. And that's why for my very first study, we conducted a cross-sectional study or community-based study to understand what are risk factors for heart disease in African immigrants. So that's how it started. And that appreciation for if there are gaps in knowledge and gaps in data, we need to close them if we want to improve the health of African immigrants. Several years later, I also got interested in gaps in data on Africans and their heart health. We know that, in fact, there are a lot of studies that have examined different health conditions on the African continent. But one of the things I've noticed is that for some strange reason, a lot of the investments in research is on infectious diseases, right? So it's almost like we are forgetting that Africans have hearts too. So if it's malaria, if it's HIV, if it's TB, you'll see a lot of data. But unfortunately, for heart disease, I noticed that we have fewer studies conducted to understand the burden of heart disease, but also to intervene, designing trials, designing programs that will help reduce the burden of heart disease. Now, when you also look at funding priorities for research in Africa, most of these grants are for what? Infectious diseases. So one of the things that I and others in this space have been advocating for is we need to close the gaps in data. We need better surveillance systems to capture the true burden of hypertension, diabetes, and cardiovascular disease. And when we have that information, we need to use that to invest in programs to reduce the burden of heart disease. Now, why does this matter? As we think about sustainable development goals, overall, if we do well to reduce the burden of infectious diseases and people live longer and healthier without these conditions, they are also developing non communicable diseases as well and developing hypertension and heart disease. So if someone dies prematurely from heart disease, we have failed in our mission to advance health. And so we need to invest in data and research studies on the continent to be able to address the burden of heart disease in Africa, but also invest in programs to promote health for all.
So, Dr. Commodore-Mensah, when we are working with patients, when we are executing clinical trials, when we are doing studies, there's a word that always presents itself, and that's trust. As it pertains to privacy, we're so private, and security. When you're working with the communities, how do you overcome, I shouldn't say overcome, how do you gain the trust of communities so that they understand that we're doing this for the greater good? This is a way for us to get new information for the greater good. So what kind of lessons have you learned that you can share with us in helping gain trust of communities so that we can improve our data repository around heart health and other chronic diseases?
As you just alluded to, trust is an important prerequisite to even engage in communities in research. And one of the things I've learned over the years is that trust is earned. And I'll share two quick examples of the nuances when we think about trust. Now, when we conducted our research focusing on the heart health of African immigrants in the US, and I approached these churches in the Maryland area and I said, I'm Dr. Yvonne Commodore-Mensah, faculty at Johns Hopkins. I mentioned the name Johns Hopkins. There were people who were interested and were excited, and they said, oh, wow, you're from Hopkins, and you're also an African immigrant, and you want to help improve the heart health of the population. So they were more open. The faith-based leaders that I approached were more open to hearing more, but they were also concerned about um, privacy. They also, as leaders of the congregation, didn't want to expose their members to um, any practices that would expose their health information or result in any breaches in confidentiality. So I had to explain what is research, because people think about research and they think about bench science and they say, oh, I don't want to be used as a guinea pig. So I had to go to these churches on a Sunday, sit through service, and meet with the pastors after service to explain what we were trying to accomplish. So, and that trust was earned over time. And so once we got the faith-based leaders to really understand what we're doing and accept it, they were able to champion our cause with their congregation. So that was so once we were able to overcome that hurdle, and there were people who, even some of the faith-based leaders, volunteered to participate in the study, and that was very compelling. Now, I've also done work in the Baltimore area, and unfortunately, we know that in the U.S., there are a lot of medical institutions that have, in terms of their history, not served communities well, and there are instances of Black people, and I'll use examples such as the Tuskegee syphilis study, where unfortunately Black people were not treated in a humane way, where they had syphilis, and when there was treatment, they didn't get the treatment. So there are all of these historical sort of contexts that we conduct research in. And so even at Johns Hopkins, there's also a history between the institution and the community. And Henrietta Lacks. So this is the whole history with Henrietta Lacks. So we also conducted a study in Baltimore called the Engage with Heart study. And again, thinking that I'm a Black faculty member, if I show up, I'll be received a similar way as I was received with the African immigrant population. But because I was also wearing another hat, which was as a Hopkins faculty member, there was some resistance that, hey, what is this about? What are you going to do with our data? So again, I had to do the work. My whole team had to do the work of gaining the trust of these leaders. So that really shows an example of how context matters. So, in one context, being from Hopkins was celebrated. In another context, there were questions, and I had to answer
Mm.
those questions. So, I think that it teaches us the importance of doing the work to earn trust. And in the case of Baltimore, once we explained what we were trying to accomplish and we partnered with the community, we were able to conduct the study effectively. And one last thing we did was that in terms of the research team, we ensured that the research team members were reflective of the population that we were trying to recruit. So we had research assistants in the case of African immigrants who were from different African countries. And so the participants were excited because in the African context, education is really valued. So they were willing to participate. But also in Baltimore, we brought along students from different backgrounds, and they were more willing because, again, the group that showed up was reflective of the population.
Thank you so very much for reminding us that communities are not monolithic. And when you show up, you have to show up to represent the community. It is not what's good for this group of people may be a reason for hesitation for another group of people. So it's important that teams show up in communities around heart health and any other engagement of the community looking like the community and having representatives of all of those spaces and community. And you said something that intrigued me. Um, so as an African immigrant, and we have these tools, we'll call them, that are developed here in the West. So when you go to West Africa, to the continent, how do you transition from this concept, these tools that are developed in this West to go to West Africa and just is it just easy to apply those in West Africa as it is in Baltimore? How do you make that transition so that it's the other piece you're going to tell us about, and that is the culturally informed innovation? How do you do that? What do you recommend for other people who are interested
And that's a great question because it's very easy to think about innovation in the sense of, well, we've used this tool, and I'll use an example of a mobile health application.
in?
We've used it in the US, it works great, everyone gets it. So we're essentially going to copy and paste it and use it in for instance, Ghana, where we've done a lot of our work. And that's
Mm,
not the case. So we're actually conducting a clinical trial now, and there's a mobile health application that we're using to help control hypertension. And so the app was actually developed in Europe and now is being used in the US. And now we're trying to use it in Ghana. So very complex. But we have had to meet over the past 3 months with the app developers to actually tailor and adapt the app. Because for every single page of the app, we are intentional. And I think that's one of the things that's necessary. A thoughtful examination of what does this solution or technology offer for the population, what's the intended impact, and how do we thoughtfully make sure that we're tailoring the tool. So, for instance, the images. So, the original app had pictures of, for instance, a white man or a white woman measuring the blood pressure. And we met with them and said,
mhm,
we need to adapt these images so that for a Ghanaian man who has hypertension, who's monitoring his blood pressure, that he sees himself in the app. And so they've been very receptive and adapted the images, but also the language. So just making it
mhm,
clear that in terms of health literacy, it may not always be the same. So how do you take a paragraph and distill it to what people should really know? It can be a sentence or two. So really simplifying the language, also using more infographics and icons so that people who may have lower health literacy can still use the technology. But I'll lastly say that when we think about innovation and cultural adaptation, one of the earlier studies that we conducted in Ghana, we use a mobile health application And we designed this trial and it worked so well. And we actually adapted that intervention for a trial in Baltimore. So when we think about innovation, it's not always from, Western countries to African countries, but there's also the potential to learn from the work that is being done in low and middle income countries and adapt those lessons for populations in the US as well. So that's the concept of reciprocal innovation. You mentioned that we not only think about innovation coming from high income countries, but being
Right.
open to learning from different contexts.
I think I grew up understanding very clearly that you can learn from everyone. There's something to be learned from everyone. So this kind of innovation is critically important, particularly when we are moving from one culture to the other. Because I think Dr. Commodore-Mensah that an apple is an apple regardless of where you are. So there are some commonalities
Yeah.
regardless of the differences in culture. There are some commonalities that kind of bring us back to a central place. So now we're going to come back and talk about the heart of your heart, and that is being a nurse. So we know that nurses are the black backbone of community care, and they are trusted professionals. So as a nurse, and you're working directly with local communities, how do we collectively look at technology and how it can improve health solutions and make it trustworthy on the ground in the community as a nurse? Because, it's interesting because, and I'll just use going into a practice setting, everybody looks for the nurse. They really don't look for the doctor. They wait for the doctor to leave. And that's because it's a matter of speaking to people on personal terms. So, what is the advantage that nurses and other professionals like nurses have in community engagement that makes that engagement valuable?
This is one of my favorite topics. And like you said, this is the heart of our conversation, which is
Mhm.
how do we elevate nurses and really demonstrate the value that nurses bring to the table in terms of improving health? I'll say that often patients want to please their physician or provider, so they'll give you the answers they think you want to hear. You ask them, "Yeah, how's it going with your blood pressure medications?" So yeah, I'm taking them, and you look at their blood pressure readings, and it's not reflecting in their numbers. So they want to please the provider. But I think with nurses and in terms of how we're trained, we know that we can be real with people, right? They feel like we're more accessible, so we can, have those hard conversations and non-judgmental conversations. Not that one profession is judgmental; it's just comfort, right? And as the number one trusted profession, and this is one thing that I'm really excited that nurses are known for. How do we leverage this trust, right, beyond the bedside? That's what I like to say. That yes, we are known to provide, patient-centered care, person-centered care, but how do we show up in communities, right? Community-based organizations, faith-based organizations. So, for instance, for Heart Month, it would be amazing to mobilize nurses to be more visible and educate people about preventing heart disease, managing hypertension. So that's a lot of the work that our research team does in the Baltimore, Washington, D.C. area. We volunteer a lot for community-based events. We do screenings and increase awareness. So that's an opportunity for nurses to be more visible and leverage the trust that people and communities have in us to be able to increase awareness, but also technology. And that's what you alluded to. I always like to say that I see technology as a tool. Technology does not replace that human interaction. And now I know that in the age of AI and machine learning, there are people who are saying, well, AI may take some of the nursing jobs. That's never going to happen. What AI and machine learning could do is actually help nurses and other clinicians work more effectively. one of the things most nurses complain about is documentation, right? So
Mm.
most nurses want to be at the bedside educating patients and not spending hours doing documentation, right? But now there are tools, there are scribes that are leverage AI and machine learning so that as you're providing care to someone, you're just dictating what you're doing and it creates a structured note, right? So imagine the potential of this also in communities where, as we engage with communities, we can leverage, some of these innovations to increase awareness. I just became aware of an example where you can upload a photo of a clinician and use AI to generate a video that summarizes, for instance, how to measure your blood pressure. So you could have a video of Mr. Payne going through the instructions. He sit, legs uncrossed, arm at the heart level, and a way that people can still relate with you because they know you, you're familiar with them, or familiar to them. So I think that's the beauty of technology, and I think we need to embrace and identify what's the best use for technology and how can we empower nurses and different healthcare professionals with these tools to work more efficiently and reach more people, right? So that's the other promise of technology, improving access. We know telehealth, telemedicine allows us to do that. You don't need to be face to face with someone to deliver health education, and telemedicine and telenursing allows us to do that as well.
So I have a personal story that ties in what you were just talking about. I was at one of my providers yesterday, and the nurse was in my exam room, and there's a patient next door. So they knocked on the door, and the nurse said, "Well, just a minute." So she went to the door, and so the patient next door said, "Can you come here for a moment when you finish?" And she said, "Well, yeah, is it an emergency?" And he said, "No, I just want to ask you a question." So she finished what she was doing, and she left and came back, and she said, "I have to tell you this," because she and I had talked about something. She said he wanted to know there was a personal health record platform. I won't call the name.
Mhm.
So,
Yeah.
so the
Yeah.
doctor asked the patient, "Well, do you use this personal health
How far?
record platform?" And the patient says yes. So they called the nurse because they didn't know what it was. So it was the interesting part about this. She explained to, and as I was leaving, the patient told the receptionist, "Oh, I'm going home and look at my personal health records platform." And he called the name. So it's interesting that one provider mentioned that, but the other provider actually clarified it so that it really became an active tool for the patient. And the patient felt empowered that they now could call the name of the tool. So that's what technology does when it is used in an interdisciplinary team for the benefit of improving a patient's outcome. So I was smiling as you said that because this just happened to me yesterday. But we know who explained that and made the patient feel that they knew what they were doing. So as we go to our last stretch, and I'm sure that everyone has been enjoying Dr. Yvonne Commodore-Mensah and all of the information that she's shared with us. So we want to talk about what happens for the future for this workforce development component that we're looking at that integrates innovation, technology, career development. And as an educator, what do you see, or what would be your vision for the next generation of nurses? And how should we be preparing them to be better clinicians?
That's a great question, and we know that uh, we have a big problem when it comes to our health workforce.
Mm-hmm.
We don't have enough physicians, cardiologists, nephrologists, you name it, for all specialties. We don't have enough healthcare professionals. What we also don't have is diversity in our health workforce. Um, we know that there's a body of work or research that has shown that when there's some form of cultural concordance, it makes patients feel comfortable. They are more open and honest about some of their issues, and they are able to relay information in an easier manner. I reflect on the times that I worked as a cardiac nurse. And if I walked into a room and let's say the nurse was African, and from my name, they could tell I was African too, they would just light up. And, they knew that I would break things down in a language that they could understand. So there's value in diversity, because we want to make sure that the health workforce that we have reflects the overall U.S. population. So we need more nurses. We have a shortage of nurses in the U.S. And that's also because we have an aging population. A lot of the nurses who were trained decades ago are retiring, and we need to replace those positions. And we're not doing enough to replace those positions. So if anyone's listening and they want to consider a career in nursing, a shameless plug that now there are accelerated programs. If you have a bachelor's degree in a different field, you could become a nurse in about 15 months or so, because we need more nurses, and nurses are amazing. It's a very rewarding profession. But to answer your question about how we should train nurses differently, I think we should be training nurses for the future of health care. And one thing we know is that technology, AI, machine learning is having a stronger presence in how care is delivered. And I also know that there's a segment of nurses who are actually opposed to integrating AI, and I feel that often people may oppose something if the work has not been done to explain and demonstrate the value, right? And so I think we're all learning about the potential of AI and machine learning and really understanding its place, because the reality is it has a place. Whether we like it or not, it's being used as we speak. The last time I was in the hospital and the physician walked in, he said to me, I just need your permission to use my phone to record our conversation. And he didn't do any documentation while he was in the room. He just had his phone next to him, and as we were talking, it was recording our conversation, and it was going to take that recorded conversation and create a structured note. That the future is here, right? So how do we train our nurses in nursing school to understand what are the different applications that are available? What are some of the resources? Because for me, I see it as a resource, a tool to make life easier. And a lot of nursing schools are also leveraging AI platforms and educating their students. I've actually used one that allows you to upload PowerPoint slides that are not very exciting, but upload it into an AI platform and generate flashcards, podcasts, quizzes, and really allows you to tailor education. So again, that's one use of AI, not just to improve, how we provide care, but also to educate, right? And make sure that people are able to learn based on their learning style and offer options to help understand maybe difficult concepts as well. So I'll say that for the future of nursing and the entire workforce, just really um, em- embracing and being open, but also advocating for the appropriate use of technology and making sure that as these AI models are being developed, we have a seat at the table, right? That we contribute to how some of these models are developed and how some of these technologies are developed, so that the final product is something that is actually useful, because sometimes people develop apps with engineers and don't bother to engage nurses and other clinicians in the process, and they have a final product that is not useful or has some biases. So that's another thing we didn't get at, but there are potential biases that may be perpetuated when we use technology. So we need to have a voice and really contribute to some of the development, but also the implementation as well.
So, Dr. Commodore-Mensah, I want to end today to have you give us a takeaway. And as a first or second step that supports culturally informed innovation for heart health, and especially regarding West Africa, as president of the Ghanaian Nursing Association. I hope I got that right. So I'd like for you to just speak to that for a moment. And how do we get better about supporting culturally informed innovation, particularly for heart health?
Yeah, so my general interest is in heart health in
Mhm.
African descent populations locally and globally. I care about heart health overall, but we know that unfortunately there are disparities in health outcomes within the US, but also when we compare what we know about heart health in the US and globally. So, um, my big takeaway is that there's a need to collaborate. We can do so much more together. And so that's the heart of, or the motivation for creating the Ghanaian Diaspora Nursing Alliance, which is an alliance of nurses from all over the world who are linking with nurses in Ghana and the African continent to see how can we learn from each other. So, for instance, we have an annual conference where we have nurses from the diaspora and leaders actually show up on the continent, right, and offer workshops, have panel discussions, and really understand what it means to collaborate to reduce the burden of heart disease, what it means to collaborate to promote blood pressure control. So that learning that happens where you put people from different backgrounds in the same space to tackle a unique problem like heart disease, I think is where the magic happens because, as you said before, there's so much we can learn from each other. So the power of collaboration would be sort of the main takeaway. Let's find opportunities, reach out, extend a helping hand to others, but also be open when others reach out to collaborate to reduce the burden of heart disease.
Can you restate for us the Alliance's correct name?
So it's the Ghanaian Diaspora Nursing Alliance, or GDNA. We like to say Ghana in our DNA or Africa in our DNA, but really we don't check or verify anyone's passport or their nationality. We just care about collaborating with people who are passionate about global health, but also just uplifting the nursing profession globally.
Now, Dr. Commodore-Mensah, where can we reach you on social media?
Well, yes, I'm active on Twitter. If you search under my name, Yvonne Commodore-Mensah. I'm also on Instagram as Dr. So Dr. Commodore RN, so Dr. Nurse, Dr. Commodore RN on Instagram. I'm also on LinkedIn if you search under my name, Yvonne Commodore-Mensah.
So you've heard it, and we are always excited to talk to Dr. Yvonne Commodore-Mensah, who is Professor and Associate Dean of Research and also Director for Local-Global Reciprocal Innovation at Johns Hopkins Center for Health Equity. Thank you so very much for taking time out to talk to us today. We'll see you on your social media platform. I'm Kermit Payne. Thank you for joining us, and remember to be kind to yourself and be kind to others. Thank you.
Thank you for having me.
We would love to hear from you. Send your listener letters, questions, and topic requests to media@the1jg.com. LifeBeat, the podcast, is sponsored by One Joshua Group, your strategic source for engagement to improve life through better health, education, and information. To learn more, visit us at the1jg.com or follow our work on social media using hashtag 1JGCollabs. One Joshua Group, advancing access to healthcare and education by joining what you know with what we've learned.